Welcome, everybody. I think we'll make a start because it is a couple of minutes past 10. Thank you for all of those who've come up from Cambridge and battled the A14 this morning. That explains why we're slightly late. This is the meeting of the Adults and Health Committee on Tuesday, the 9th of December 2025. The County Council allows filming and photography at its public meetings, so feel free to take pictures and use social media during the meeting. Please, though, can everyone turn their mobile phones to silent or vibrate. This meeting will be live streamed and a recording of the meeting will be available on the County Council's website. There's no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting and we will leave via the side doors and use the fire escape next to the kitchen to assemble in the car park. I will also adjourn for a comfort break if the meeting goes past 2 hours. If we can just move on to item 1, which is changes to the committee membership since last meeting. If you recall, these are in accordance with the County Council's decision about the changes to political representation. And we're noting that Councillor Malinowski has left the committee. Councillor Black, welcome, has joined the committee. And Councillor Machini has replaced Councillor Black as a substitute committee member. There's also one further change to report since the meeting papers were published. Councillor Stephen Fisher has joined the committee. He succeeds Councillor Andy Osborne, who becomes a substitute committee member. Any comments on any of that? No. Let's move on to apologies for absence and declarations of interest and announcements, which is item 1. Will the Democratic Services Officer let us know of any apologies, please, Rishinda?
Thank you, Chair. Apologies have been received from Councillor Kane, from Councillor Green, who is substituted by Councillor Rees, from Councillor Stephen Fisher, and from Councillor Christine Whelan.
Thank you. Item 1 is also, does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest relating to the items on the agenda that are not already declared in their register of interest? No, thank you. Item 2 is the minutes of the meeting on the 9th of October and the minutes action log, which can be found on pages 5 to 22 of the agenda document pack. We're being asked to approve the minutes as an accurate record. If anyone objects, can you indicate now? No, everybody is happy with the minutes, so I will sign those later. We will take that as carried unanimously. If we turn to the minutes action log, are there any questions on the action log, or can we take this as noted? David?
Yeah, sorry, just interesting on number 8, it said that an event planned for the end of November, beginning of December, and it says we'll be notified. I'm just checking. Is there a date yet, or?
Related to the behaviour change research. So we're still waiting for a final date from the university. So it's not been in November. Don't worry, you haven't missed it. It will be in the new year and we'll circulate a date when we have one.
Any other comments, questions? No. I think there was something else about the all carers action, all age carers strategy, which had been approved by a committee but did not appear to be working. Officers advised, but that an update would be provided to spokes. Have we had that, David? Is that something that we should be getting shortly, Patrick or Sally?
I thought we'd had an update at Spokes on carers, but we can certainly make sure that we get onto the next agenda. We've got a full update and we've got work already in train on the refresh because the the carer strategy is 22 to 26. So we're currently in mid-review of the carer strategy. So we'll make sure that we bring an update to the next spokes. I think the 14th of December is the next one. So it may be just of a timing issue. It may be the January spokes if committee are comfortable with that.
Okay, if there are no other comments, we'll note the action log. And item 3 is petitions and public questions. None have been received this month, so we'll move on. Item 5 then is the public health strategic items and tobacco control strategy, which can be found on pages 23 to 58 of the agenda pack. Sally, as Director of Public Health, will introduce the report.
Thank you. So the paper as it is in your pack is in 2 parts. The first part talks through following up from the strategic plan that came in May, where we outlined our priorities from a public health perspective for the population and our priorities for activity. Following on from that, this outlines the strategic areas of work that form part of that plan. So we lead particular multi-agency partnership strategies from a public health perspective. And there is a lot of work going on around these strategies, but they won't necessarily otherwise come through to committee because they don't have a financial decision attached to them. So it's to give assurance and oversight of the key strategies that we will be leading on from a public health perspective as part of the strategic plan delivery. So the paper on page 26 onwards has a table within it which outlines the key strategies that are part of our strategic plan. The table is aligned to the 4 pillars of our strategic plan across the whole of public health delivery. So that table outlines our strategic areas of work as part of that, and a timeline where we have suggested that it might be helpful for committee to see some of the work being updated here, depending on the timelines of those strategies. So, for example, suicide prevention strategy, which is across Cambridgeshire and Peterborough partnership strategy, we suggested it might want to be seen at committee in autumn next year, just as a suggestion. And tobacco control, we are obviously then focusing on through this report. So there's other strategies within there that are outlined, physical activity strategy and the core principles of that work and the timeline where it may be helpful for it to be seen at this committee. So they are outlined across that table. I'm happy to take any questions on any of those as sort of high level overview of those strategies. And then the second part of the paper goes into a deep dive across the tobacco strategy, which is then in the second part of the paper.
Shall we deal with the first bit
Yes,
first?
we pause there, and then I'm hoping that I have colleagues that come in, there you go, like magic, to talk to the other bit. So yeah, happy to take the first part with the strategies overview, and then we'll move on to the tobacco element.
Any comments, questions on the public health strategic item? I think you've flummoxed them. I think that was extremely helpful, and it's quite a good high-level review of everything that you're doing and why you're doing it rather than the other partners doing it. Okay, well, let's move on to the tobacco element.
Thank you. And just the final point on this earlier items around the strategies is that these are all the strategies that we lead on from a public health perspective. So there will be other pieces of work that we're involved in or supporting others to do. But so we've aimed to cover those that we are taking a leadership role on. So then I will just introduce the tobacco item, and I'm hoping Val and Bridget, if you come to the table, you can then talk to it in more detail. So as I mentioned, this is a Cambridgeshire and Peterborough tobacco control strategy. We've been working in partnership with across Cambridgeshire and Peterborough on tobacco control smoking prevention for a number of years through a partnership approach, which is called the Tobacco Control Alliance. And there's been recent work to refresh and update the strategy, following on from a summit that was held earlier this year with all partners coming together to look at what the current issues still ongoing, what are the actions that are now needed, how do we refocus? And this strategy is following on from that summit and all the discussions and data that we have at this point in time. So I will hand over to Val and Bridget to talk to that in more detail. Thank you.
Thank you, Sally. Yes, as Sally described, there's a history to a strategy, and we've been working together for numerous years. I think probably the situation has changed recently in the past 4 or 5 years, where we've seen marked improvement in smoking rates. But that is not the whole picture, of course, because within those smoking rates dropped from where we were 30% of the population smoking now to in Cambridgeshire 10.6%. But within that, there are certain groups where rates remain very high, and that's where our focus is with this strategy. The other contextual thing is the smoke-free generation policy, which is sort of going through Parliament on an ongoing fashion and has various stages. And probably the most important thing with that is that at a future date, young people will not be able to, well, nobody will be able to buy cigarettes. And there's been additional funding that's come to public health departments of the country to strengthen stop smoking services. The other important factor, of course, which always has presented another angle is vaping, the appearance of vaping, and the implications that has had. And that's detailed in the paper of why and when we recommend using vapes. And the other element to the legislation is enforcement. And that is very much around illegal tobacco and illegal vapes. So we shaped the strategy with 9 strategic ambitions, which capture very much working obviously with children and young people, as that's always where we start, then targeting certain groups, most notably the homeless, people in drug and alcohol services, and people with mental health conditions whose rates of smoking range up into the, well, anything from between 50 to 80% of them smoke. Then strengthening our services to the general population using different types of methods, and then strengthening enforcement as well. And alongside that, we've developed quite a detailed delivery plan, which I'm sure Bridget can fill in the highlights of that.
Thank you, Val. Thanks, everyone. So the detailed delivery plan is in the appendix, but within that we are looking at what we are currently doing, but also what we can do differently. So increasing work around the prevention work around healthy schools work, and also working with settings with children that not necessarily in mainstream education. And then it's how I think a big emphasis is how to reach the groups that we know have higher smoking prevalence, that are potentially less likely to attend to traditional stop smoking services. So how can we reach those people to engage them in our services? And lots of the work we're doing is working with organisations that are trusted by people with smoking prevalence. So embedding kind of stop smoking support within settings people already trust and feel comfortable in, to reduce prevalence. So our ambition is to be smoke-free, which is a 5% or less by 2030. We had some recent data since this paper was written, and prevalence has reduced to 10% now. So we still need to reduce it by half by 2030. So within the appendix, the whole delivery plan is laid out of what we're going to do over the next 5 years, well, 4 years now. But if you do have any questions, please let me know.
Thanks, Bridget. Sorry, Val.
And just to follow up on that, there is a small section on achievements to date in there as well, which details some of our work and where we think we are making progress to date with this new approach to addressing smoking.
Excellent, thank you. Any comments, questions? Yes, or questions or whatever, Steve.
Thank you, Chair. I think public health is at its best when it is supportive and educational, and it's at its worst when it is controlling and authoritarian. And there is a danger that things can slip both ways. So I've never been a smoker. I've never smoked in my life, but I do support people's right to choose to do so if they want to. The idea that the government will ban all cigarettes is terrifying to me. I think it'll be that, and then it'll be caffeine next, or whatever the next cause celebrity is. And I just think it's the wrong path to take. I don't like the language in some of these messages. Talking about tobacco control, I would prefer tobacco education. Talking about forcing people to stop, I would prefer encouraging and educating people to stop. And I'm sure that's a lot of what we do, but that the more controlling language creeps into these documents. And I know that there are some people in public health, not all, who are quite militant about this, probably with good reason from their point of view because of the health outcomes. But nevertheless, we all choose how we live life, and we choose what's going to eventually kill us. A rock climber might fall to their death. A boxer might suffer illness later in life. Every choice we make has upsides and downsides. And I do feel that we must retain people's control so that they're able to choose. If they want to vape, they should be able to vape. If they want to smoke, they should be able to smoke. And if they say, leave me alone, we should leave them alone. Thank you.
Okay, let's pick up some other comments. Richard and then Lucy.
Good morning. Let me just get to my note. I wanted to ask on part one, but I didn't get to my notes in time. Sorry about that. Shall I continue to do that?
Find your note.
I've got the note now, but
God,
are you happy that I asked those questions? Yeah. So one of the things is I didn't read anywhere in the strategy health in all policies. And certainly in the past, there was a specific budget line for that. I think we had a specific staff member. So I would be grateful if Sally could comment on that, and if relevant, it be the strategy be amended to take that. The second one is on the bit about environment and transport, social determinants of health. Strongly support that analysis and the work that's going on there. But as I have said before, I think it's important when those policies come back to us for review, that we try and understand the value added of the public health approach, because there are lots of good and well-meaning people working on environment and transport in the county council and in our partners. And I think it's important that by saying that it's part of the public health strategy, we understand what the value added comes from that health perspective, and we have some indicators that try and show that. On suicide strategy, I simply note that when we did health scrutiny with CPFT, we were unhappy that the trust had been transparent enough about past mistakes. You know, they say there have been past mistakes and they've improved them, but they don't go into any detail when scrutinised on what and how. And so I think I wanted to just feed that comment in. I wanted to ask Sally, I'm sure she can only give a preliminary answer, but we're faced with this new Central East ICB, much bigger. And so that's a very different NHS partner for the county council in our public health work. And I would be interested to hear Sally's initial thoughts about how that will change and how that could still be best coordinated. And finally, a comment rather than a question. You know, it's great to see the timetable for looking at the specific policy areas, and I look forward to those discussions. But I want to emphasize that when we have those reviews, it's really important to know what has but hasn't worked, and to have honesty and transparency about that, and where we're making changes to hope it will work better. And we don't always see that in reports. So I'm saying in advance, I very much want to see that in the reports that come to us. Overall, obviously, very strongly supportive of the strategy. Thank you.
Okay, thank you. I'm conscious there's quite a lot there, Lucy. So if you don't mind, we'll get answers to the points that Steve and Richard have raised and then go further. So Bridget or Val, do you want to start with Steve's comment about that we are trying to educate people? We're not trying to control them and tell them what they can do.
I think embedded into a public health approach is what we call our behaviour change approach, which is not about control. It's about asking people to think about their behaviours and the implication that their behaviours will have for their health. And I think that underpins all our services, in fact, whether it be the Healthy Child Programme right through to stop smoking services. And it's that principle, I think, saying this is what, think about your behaviours, think about the implications for your health, and do you want to continue with this behaviour? And I think that's implicit in that. Let
Steve come back on that first.
Yeah, just wanted to say I'm pleased to hear that. I thought that would be the case, and I'm pleased to hear it. But we ought to bear in mind that if you make something cool by making it wrong, that sometimes creates the opposite of the outcome that you want to achieve. And in fact, smoking has become uncool, I think, these days, and vaping more cool, I think. And you've got to keep an eye on that sort of thing, because if you take a too strong approach, you will actually be the result will be counter to what you would like, I believe. Thank you.
Thank you. Sally, I think the other points from Richard were probably geared towards.
Yes, I just want to add something on the tobacco and the personal choice item as well, though, before I move on to Richard's comments, is that if somebody is addicted to nicotine, then they do have their personal choice taken away from them to an extent, because they are addicted to the nicotine. So it's not necessarily an absolute personal choice once the addiction has happened. So what the tobacco control agenda is also about trying to support or avoid people getting addicted in the first place, particularly young people. So the control bit is about controlling some of the supply of access for young people as well, in terms of controlling the advertising for young people to get them hooked when they are really too young to, and also illicit tobacco, where it's then being able to be sold at a really low price that brings people in to be addicted at a much earlier age and much more accessible. So the tobacco control bit is also about working in partnership with trading standards and environmental health, etc., to try and manage the supply of tobacco, as well as the do people want to smoke bits. So it's a whole system approach. So I just wanted to make some of those points. And then coming into Richard's points, health in all policies is absolutely in there, although the phrase health in all policies perhaps wasn't written in there. So you pulled out some of the points around transport and health, and that really is one of the elements of health in all policies. So we're thinking about how do you build in healthy policy into some of the transport work, and working across into our transport highways, active travel teams to think about how do you build in health into that agenda is very much health in all policies, but I just haven't written that word in that strategy document. So all of those areas within that section of the table are essentially health in all policies. So thinking about healthy place, the built environment, transport and health, housing and health is all about how do you build in health into health maximisation, thinking about tackling health inequalities through those wider system areas of work. And absolutely agree with you that there's lots of work that's happening around housing, transport, planning. And then what's the added value of bringing in the public health voice into that, and trying to make that really clear is the challenge around some of that work. So really thinking about how can we support people to have a clearer evidence base around what are the actions that might help tackle health inequalities through that work? How do we think about the levers that we might have to manage hot food takeaway locations across the county and have a a healthier high street. So all of those ways of working to try and enable the healthier environment to be the kind of go-to for those areas of work. So working with the districts around their local plans, working on health impact assessments for large developments. So all of that is part of that work, and really trying to be explicit about the added value of thinking about public health through that. And then just that last point was around, so the suicide prevention strategy, I think that's just for noting, but we, through that work, are very much linked into the Mental Health Provider Trust as part of that. And it's very much linked into as well the what's called the ABU, the Provider Forum Network around mental health and learning disability and autism. So the suicide prevention strategy links into that work stream. And then just the last point that you mentioned was around the ICB and how we think we might be keeping focus and working with partners with the changes to the Integrated Care Board not being Cambridgeshire and Peterborough anymore, but being a bigger footprint, so Central East. It is obviously in development. So we are working hard to maintain those relationships, and there's lots of people in the system that are people that we have worked with for a long time and are known still to us, so that's helpful. In the new structure, there will still be a Cambridgeshire and Peterborough footprint as well, so there is a lead role for Cambridgeshire and Peterborough who we work very closely with and is now in post and is part of the Health and Wellbeing Board and working on the neighbourhood plans collaboratively with her and the wider team. And then just from a public health perspective, so the Director of Public Health across the new footprint, we have a collaborative network approach and are meeting actually next week, but we'll be having regular meetings to think about how do we have a united public health voice to make sure that we're keeping a focus on prevention, health inequalities, using the evidence base, thinking about evidence-based service delivery. So really trying to work that through, but it will be a challenge. I do take that point.
Does that answer your questions, Richard?
It does. I made one short comment, which is Sally was present when we did health scrutiny on the chief executive of the ICB recently. But to members of this committee, it's potentially going to be a very big change in relationships. And it's one that I hope this committee can also be very strongly looking at in support of our effective public health function. Thank you for all those answers.
Thank you. Lucy and then David.
Thank you. The first thing I want to say is that I agree with Steve about the importance of making sure that public health and the way in which things are phrased in public health is very much about support and not about criticism and being derogatory about people. And I think our language in this is really important. And Val, I'm really sorry, but when you say people should think about their behaviours, it makes me think I'm back in a classroom and I'm being told off. So I do think we need to be careful about our language because actually I think that language is in itself slightly triggering. The thing that I really wanted to focus on, though, is about the really strong, there's an extraordinary bit of data in here about the relationship, the number of people with mental health problems who smoke. And that figure is off the charts in comparison with everybody else. And thinking about the number of the people who, I mean, the proportion of the population with kind of known mental health problems is not a huge proportion. And if that number of them are smokers, that group is clearly a group that we should be thinking really carefully about how we approach supporting them. But also that for that group being told you should stop smoking is just going to add to their mental health problems. So clearly there's a need for that support to be probably mental health first and smoking second, if that makes sense, because it's going to be extremely difficult to deal with addiction issues if you are also suffering from quite severe mental health problems. So my question really is about, in a sense, mental health issues are something that we would normally think were a health problem, and for health services to
deal with. But actually, if we should be thinking about that as part of our public health role. And there are quite a lot of things, thinking about Richard's point about health in all policies, that there are quite a lot of levers that we as a county council have where we can be supportive of people and making sure that our kind of smoking cessation policies are joining up with supporting people with mental health problems in the space of skills, in transport, in sometimes just in kind of community support, and making one of the things that is very good for people's mental health is often being outside in fresh air. How can we support people to have that opportunity? Because sometimes people with mental health don't have places where they can kind of access green space. I don't know how much of that we are thinking about as part of our anti-smoking policy, because although it doesn't necessarily feel as if that should be immediately an anti-smoking thing, I suspect that given that group have such high rates of smoking, we should be using some of our efforts in those kinds of areas. So that's my specific point. Thank you.
Val, before you come back,
I think
before you come back, Val, I think Lewis wants to add to Lucy's comment about mental health, and then we'll come to you, David.
Thank you, Chair. Yes, just probably to complement that and to address Councillor Netzinga and Councillor Tini comments. On page 38, understanding smoking behaviors and driving action, I would like to ask the question, how is behavioral insights research being embedded in the service design? I think that is going to probably help us understand a lot of how people behave, how the choices they make and why they make them, and probably give us a little more basis and grounded on the evidence and the reasons why and the actions that we must take. So just to add to the concerns of both councillors here. Thank you.
Val.
Thank you. I think probably just to talk about this area, both I think people with mental health, but homeless and a couple of groups that experience real high rates of smoking. And I think this new approach is we've accepted that our normal, the 28 days quit intent just isn't the approach. And so we've commissioned CPLSL Mind and Housing First Here to work and for them to sort of have their own small smoking teams and work within those organisations, and those people who know their clients, they know the challenges that they confront and how they need to work with them. And I think that's been a big shift in our approach, to have a much more targeted approach, and the acknowledgement that the usual 28 days, 6 weeks, tick the box, it doesn't work at all. And we piloted at the Ferry project in Finland. We started nearly 2 years ago now, and the results have been quite amazing. But it's not, it's a longer process, and people spend a lot of time with them and address all their problems, not just, it's seen as part of helping them and supporting them. And I think another part of that you said about joining it up. I think Bridget has spent many years doing training with different organisations and so forth. But I think what we're trying to do at the moment is both the SMI health checks and the learning disability health checks to make sure that smoking's embedded in them. And I've just been looking at the data, and I think there's some room, quite a bit of room there for improvement. And then I think to Lou's point about the behaviour insights research, certainly, yes, we will be using that. And I think most of you should have received an invitation to where Sheffield University, who we commissioned to do it, will be coming down to present that data, and how we've been doing some, piloting some of the findings that they've come up with. So I think, yes, I absolutely acknowledge that the rates are horrendous and that we are trying a different approach, and commission that approach as well.
Thank you. David.
Yeah, thank you, Chair. I'm not disagreeing at all, actually, with Councillor Tierney and many of the others here, but we mustn't forget that smokers bring along with them passive smokers, and this is actually quite a serious issue. It hasn't been mentioned yet today. I mean, I'm very conscious when I'm in public. If someone's smoking nearby, you can tell now. I did used to smoke many, many years ago, I'll admit, but I haven't for a long time. And we have to remember that. I myself am in favour of the location where people can smoke being restricted, as it often is. And I don't know whether the councillor believes in that too. But I think we need to be aware of the other members of the public who are non-smokers who are affected by smokers. Thank you.
Thank you. Oh gosh, that's got well. There's three gentlemen here. Let's start with. I don't mind. Do you want to go, James? Do you want to go start?
Thank you, Chair. Just want to echo all the comments with regards to the language in the report. I totally agree. We should support people who want to give up. We shouldn't force anyone to quit if they don't want to. You know, it is their right. Also, I know this is more of a national issue, but in Australia, they've been trying to stamp out smoking, and what it's done is drive the supply of tobacco into the hands of criminals, and has caused organised crime, much as it did in Prohibition in America in the 1920s. So from my experience, speaking to most smokers who want to give up, it's the fact that they wished they'd never started in the first place. So I think really the main focus should be on getting to the children first and making sure that they don't start in the first place. However, talking to parents with teenagers, they're not concerned about smoking, and the data in the report shows that it's actually vapes that are the problem. And I was quite surprised to find that it's of a higher prevalence in girls, and being a dad of two girls, that really concerns me. I think it was year 10s when I read. And the problem with the vapes is that they're clearly aimed at children, aren't they? We have plain packaging on cigarettes, and they're behind closed doors, behind the counter, and they've got horrific pictures of lung cancer, etc., on them to put people off smoking. And yet the vapes are front of house, colourful and flavoured to suck young children in to potentially a lifelong addiction. Some of these vapes have entire packets of cigarettes in them and can be consumed within a few hours, creating extreme nicotine addictions in children, which is well beyond what most smokers would manage to achieve, even on their best day. So I really think we need to prioritise vapes in this strategy, and that the fact that it's still called the tobacco strategy instead of potentially the nicotine strategy, which would include all nicotine products, including vapes and anything else that the companies try to bring onto the market to hook our kids onto these things, might be a way to go forwards. Thank you. Those are my comments.
Okay, thank you. I'm going to go to David first, Steve, and you can speak if you wish.
Well, thank you, Chair. It's a very pragmatic question based around the enforcement. I'm a bit worried saying that next to Steve now. But obviously in the last budget, the price has gone up again. We get into about £20, I should imagine, not in the near future, for a packet of cigarettes. We've talked about addiction. We talked about it being cool or not cool, but let's be honest, there's going to be supply and demand, and we're trying to cut down on the supply, which is only going to increase illegal routes of cigarettes coming in. So I'm keen on the enforcement, because obviously we're putting more into trading standards, but how are we tracking the illegal rise of cigarettes coming into the market, and obviously fulfilling those demands?
Okay, and final comment from Steve, otherwise you'll be hogging it, Steve.
Thank you, Chair. It's been such an interesting debate. I've got a few things I want to respond to. So I don't agree that we should target vapes, because I think vapes, despite the fact that they still aren't healthy, are much healthier than old-fashioned cigarettes were. And the danger is, if you close vapes down, people turn back to traditional smoking, which is much, much worse. So I think that's a bad act. I think you can have to accept the fact that some people like and take value in nicotine and are going to use it. And if you stop them using it legally, they will go illegal, and you just up the black market. So I don't support that at all. I thought it was interesting that we said our public health is working on education and support, and then 2 minutes later, an officer of the council talks about the High Street project and how they're controlling where fast food can open to create a healthy high street, which is exactly the sort of control I'm talking about. Because markets control high streets. If people want healthy restaurants in their high streets, people will open them, people will go to them, they will prosper. The fact that there are lots of fast food restaurants on the high street is because people like fast food and want to use it and have every right to do so. And we should not be sticking our nose into that at all. Thank you.
Right, and before I open it up to officers, Peter.
Thank you, Chair. May I ask a few clarification questions, mainly around implementation? But first, I think Councillor Stidlow has made a very persuasive point. Why is this still called the tobacco strategy? Why not nicotine strategy? Because the vapes are really dangerous. So I'd just like to support that question. And why tobacco? Why are we having a blind spot here to do with the vapes? Other questions are, one, we've Councillor Nessinger mentioned some of these. This is specifically in particular demographics, particular communities. It's smoking rates are higher, and one group that I notice is above the national average is pregnant women who are smoking. And it also notes in the report, of course, that there is a stigma associated with smoking during pregnancy and that this is a barrier to accessing the support. So this seems like a really, really difficult time for lots of people. And I want to understand better, what are the practical steps that are being taken, please, to support those people? Sally Cartwright, you mentioned, the whole system approach, and I'm echoing Councillor's point about exactly what enforcement activities. So quoting page 55, additional trading standards capacity to enable them to increase their enforcement activities. Can you put some more flesh on the bone for exactly what that means, please? And finally, suicide strategy. You've already answered Councillor Howitt's question. I echo his comment, the need for transparency. I'm just wondering about, so page 28, quote, implementation of the strategy will be led by a new suicide prevention manager and delivered through the multi-agency steering group, which includes NHS, police, and VCSE providers. So just a couple of questions for me. So this new suicide prevention manager, is that a completely new role? And what are they going to be doing? And who are the VCSE providers who are going to be on this steering committee? Has it been formed? And, I am interested in the governance of how this committee is going to be structured and are other providers going to have a voice on this committee? And for both of these points about how are we supporting the pregnant women smokers and the implementation of the suicide strategy, exactly how is this committee going to get the updates that they need? I see we've got quarterly reports, but often these are sort of numerical numbers. Is quarterly reports sufficient? Thank you.
Okay, there's quite a lot there.
Yes.
Most of which I wrote down, some of which I'm afraid I didn't. So you'll have to remind me if we miss anything. Who wants to start? Val, you've got your light on, so I guess that means. Oh, well, I was thinking that meant you, but.
Yes, I'll just pick up on the suicide prevention and then hand over to Val to pick up all of the points that are relevant to tobacco. And if I need to come back in after Val's finished, then I can. So on the suicide prevention, the role is not a new role, the suicide prevention manager. So it's a partnership post across Cambridgeshire and Peterborough, hosted in Peterborough, but managed across both teams. With funding from the ICB. So it's a new person that's come into post because the previous manager had left the role, and so it's been vacant for a while. So we've now recruited and that new person has started, and they will be really in a great position to drive forward this strategy and the actions underneath it in partnership with the steering committee. And the steering committee is a partnership group with various partners, as you mentioned, including police, including the NHS, including the voluntary sector, and some of that voluntary sector providers. I don't have the full list, but they will be providers that offer bereavement support, mental health support, Samaritans, those types of providers that work in this space. So the actions within the suicide prevention strategy will be multi-agency actions. And so that steering group will help make sure that all partners are delivering on their actions across those 5 priority areas for action that are outlined in the paper.
Okay, Val.
I think it's difficult to answer the questions in some way about the different perspectives that members have on the degree of control or not. I think as answering things more specifically about enforcement, for example, and the details and the facts around that, what that means, we commission trading standards to basically, it's part of the work that they do at the moment on a whole range of illegal substances and products. So they use their intelligence to visit establishments or where they hear there are sales of illegal tobacco or vapes. And I think a point to be made there is that these sales are often targeted areas where we know smoking rates are higher and more deprived. And if you look at the data, that you can clearly track that. It's difficult about changing the name for the tobacco control strategy, but I think it's a very good point, and perhaps we do need to think about the title so that it does captures all the different dimensions of smoking, because I think I said at the beginning is that the landscape has changed, and perhaps we need to have a more encompassing terminology for the strategy that picks up on all the elements that it refers to. Bridget is going to talk about vaping and the underpinning evidence for that. In terms of pregnancy, I think it's described in the paper that we work collaboratively with the NHS on their treating tobacco dependency programme. And that has supplied funding to maternity units. So we have programmes in CUH and in Hinchinbrook, and obviously in the north as well, which has specifically funded additional staff in maternity units that support women during pregnancy, and then make sure that when they go out into the community, that support, if necessary, is continue throughout the services. It's something which is, I think, in the data, we're finding quite hard. It's improved, but there is something which we are trying to understand more about. But there's an awful lot of effort that goes into that. And I think it's associated with a lot. I've worked with smoking for quite a few years and worked particularly with women, pregnant women, and usually they have a whole array of issues, rather like people with mental health issues, and it takes a lot of specialist knowledge and understanding of working with women to help them and support them throughout pregnancy. As you can imagine, there are a lot of emotive issues around smoking in pregnancy, which I think you alluded to. Bridget, do you want to talk about the thinking around vapes and Chris Whitty?
Yeah, of course. And just on the pregnancy aspect as well, it is delivered by the maternity units, but we do support that. We introduced an incentive scheme before the National Incentive Scheme for evidence to increase motivation and increase people accessing the service. We support the maternity units with facilitating access to stop smoking aids as well. So whether that's nicotine replacement therapy or vapes. So although we don't directly commission the delivery of it anymore, we are an active partner in delivering the support for pregnant women. In regards to vape, so I really understand your points, and it's really alarming the number of young people trying vapes and even going on to regular vape. I think from a stop smoking perspective, vapes are brilliant. There's so many people accessing our services that wouldn't stop smoking if it wasn't for vape. So they've tried nicotine replacement therapy, they've tried the medicines, and they've not had success with them, but they have managed to switch to a vape. And although they're not a silver bullet in the sense that it'd be better if they didn't vape, actually from a harm reduction point of view, vaping is much better than smoking. But what we don't want, we take what Chris Whitty said, we don't want people who don't smoke to vape. We only want people who smoke to vape. So it's how to get that message, because what we don't want to do is to say to obviously we want young people to not vape, but we don't want to scare adults into not vaping and to carrying on smoking. So it's the message is really difficult to get right to people.
The other Val, the other question which was raised was about children and starting early, because one of the issues about smokers is that they keep on saying, I wish I'd never started. And if we can educate children, then that might help as well.
Absolutely. And I think around 80-90% of people who start smoking start before the age of 19. And it's embedded into a lot of our services, support that through Healthy Child Programme, that's particularly 5 to 19, but also through the Healthy Schools Programme. It definitely is a place to start. And we do focus a lot of effort on that. And some of the additional funding that we've had for Smoke Free Generation has been targeted at children and young people as well. But I did want to bring attention in the paper, at the beginning of the paper, there's, I put in a time sequence in effect for the legislation and matched it against the fall in smoking rates. And just the sort of example, the Children and Families Act in 2014, which banned smoking in the presence of children, which brings attention to that, the passive smoking element as well. And that there is a kind of link between these legislative changes, and they can be seen in different ways, but certainly they have had an impact on smoking rates.
Okay, any other comments, Peter?
Thank you very much for that. The one question that arises from me out of what you said is, Val, you mentioned this, the real expertise and requirement for specialist knowledge for these really sensitive and difficult topics. So I'm just wondering, my question is, suicide strategy, we have appointed the suicide prevention manager. Presumably they have trained skills to deal with this, and there's a steering group. So that approach, is that being applied to these other areas, like in tobacco, say for pregnant women smoking? Is there a particular, so I know you're not directly involved in this, as it were, now, but is there a steering group? Is there a role that is in charge of this who has that specialist knowledge so that we can make sure we're supporting as well as possible?
There's the overarching Tobacco Alliance, which brings together all the different elements which are captured in this paper, in fact. And then within that, there is a specific group that focuses on smoking and pregnancy, smoking in acute units, because another part of the work is for people, for example, coming through respiratory services at the hospitals, to make sure that they get offered support, being particularly at risk of poor health outcomes. So yes, I think we always aim to have people that understand the target population that you're working with, because they understand their needs and the pressures that they have upon them and can offer the support in the most appropriate way.
Thank you. But is there one person whose sort of full-time job it is, like with the suicide prevention, whose full-time job it is to implement this? And who is that person?
I think it's probably Bridget has the service lead, certainly, and manages all the service, but also has a key role in making sure that all the different parts of the system are working well. And we review it through the Tobacco Alliance. It's part of the job of the Tobacco Alliance to review our progress. And then Bridget also reviews the services as well. Do you want to say?
Yeah, thank you. And within the ICB, there's a lead person who's supporting the implementation of all the treating tobacco dependency pathways. So that's maternity, then there's acute setting. So anyone who's an inpatient with an acute setting is screened for smoking status and offered support within the hospital, and also within inpatient mental health settings. So there's one person at the ICB who oversees all that work. And then out of that work, we have steering groups for maternity, acute and mental health. And within the steering group for maternity, you have ICB representatives, myself attends, you've got stop smoking services like community stop smoking services partners such as Healthy You, plus you've got the maternity services as well. So it's a whole network of people trying to implement the best pathways so the pregnant women get the best support.
Sorry, I don't want to take up too much time, but so it sounds as though there's one person at the top of the ICB who's sort of responsible for all of this, and there's a few steering groups, but I'm still not hearing, is there someone whose full-time job is implementing the strategy for reducing the supporting pregnant women to stop smoking? Is one person whose full-time job is that, just like with suicide prevention? And who is that person?
I'd be hard pushed to say full time, but the overall responsibility in the maternity unit is the head of the maternity services at Adam Butts, for example, and at Hinchinbrook. And there are staff that have been appointed using the treating tobacco dependency funding to work specifically on smoking and pregnancy and supporting women developing the pathways. And it's the same in mental health as well. And it's the same in the acute sector, according to which clinical area is being focused upon.
Can we move on?
Well, I'm still just not quite sure. Can I suggest an action item that we look into whether we should have a role made to implement this? I'm only pressing on this because I think this is a great strategy and I fully support it. But the danger with all these strategies that I've read so far in this council is that the implementation is the difficult part. And I'm not sure if there is a person whose full-time job it is to work to make sure this strategy is implemented. So I just want to see if that would be positive.
I think I can answer that. We did have a person who worked alongside Bridget, and her responsibility was to make sure that all the different constituent parts pulled together and worked. We were aiming to recruit again to that post, and that post would work specifically on making sure that this strategy has been implemented.
So is there anything else that you wish to add at this stage, Sally? No, okay. Richard.
Very short comment. I know people will comment about the tobacco strategy from their political points of view, and I don't criticise that. That's the purpose of this committee. But I would just say, and I hope you'll make some comments yourself, Chair. Our officers have been working on anti-tobacco for a long time, often with very vulnerable and sensitive groups like homeless people, people with drugs and alcohol. And the idea that they don't know that language is important and don't have really developed practices around that, I think is disrespectful of our officers. And I have every confidence in what they're doing. Yes, we're going to have a political discussion here, but I think it is important to for officers to hear that we do have confidence in them on those issues.
I am going to second you there, Richard. I think it is very important in the language of this document. I didn't read prohibition heavy language. What I read is prevention, support, a well-measured approach. And I, as vice chair and also chair of the Wellbeing Board, will be making sure that that language prevails. That is exactly the right way. And I will, I will again support you and second that comment. Thank you.
Okay, thank you. That was very helpful discussion with lots of points made across the political parties. I took away the issues about the wording being important, and I acknowledge entirely what Richard and Lewis are saying, that you are the experts on this, but I feel that we need to be educating people rather than controlling them, which I think you are saying we are doing. Well, I know we are doing, about the importance of ensuring that we're working with children, people with mental health, people, pregnant women in particular, as they are often the very vulnerable groups that we need to be approaching on this. And I will have to check with Bethan afterwards that there is a press release going out about this later this afternoon, and I'll just have to check that my quote in particular is appropriate for the discussion that we've had today. So I'm looking towards the back just to make sure that we do that. Okay, thank you very much for your comments. we're being asked to note and support the strategic direction of the paper, of the plans outlined in the paper. We've had lots of helpful comments from people, but I see no objections, so I'll take these recommendations as carried unanimously, unless anyone objects by raising their hands now. No? Okay, thank you very much. And thank you, Bridget, Val and Sally for bringing that to us. Item 6 is a flu update, which will be introduced by Sally Cartwright, the Director of Public Health. And we feel sorry for Julie, who is just recovering from flu. But there we go. That's one of these things that you get at this time of year. Right, Sally.
Thank you. So I'll just give a very brief update and then I'll pass over to Lauren to be able to answer any more detailed questions. So the committee is recommended to review and note this update. So it's an information update for noting, with in mind that we are heading into flu season and nationally there is a lot in the press about this at the moment, and the NHS nationally is seeing a lot of pressure around flu. There is more activity than seen last year around flu. So we thought it was pertinent to give an update and give some advice around actions that can be taken locally, and some reassurance of the current position. So the paper gives the local picture where possible and some of it's the national position in terms of cases that are being seen and uptake of vaccination, particularly in our high risk groups that are at greater risk of harm from flu, which is how the vaccination programme is determined around who's priority for vaccination for flu. So the paper gives quite a lot of detail and some of it's relatively technical, but hopefully is clear. So I think that I'll stop there, and I don't know if you want to add anything, Lauren, but otherwise we can just open to questions and discussion.
Yeah, I'm happy to take any questions.
Okay, let me open it up to comments, questions. Anybody? Nobody? Julie.
Thank you. I love the fact that you're giving your frontline staff the opportunity to take a flu vaccine. I'm concerned that not all of them are. What are the barriers or what are the reasons they're not taking it up?
Thanks. So we did a survey based on last year's uptake, because the winter uptake for last year was...
Lauren, could you speak a bit closer
Sorry.
to the microphone or a bit louder?
Yeah, we surveyed staff from last winter because the uptake for the voucher scheme that we offered was fairly low. And there were some barriers found, but actually largely we found that a lot of our staff are already eligible. So they had been to their GP or their pharmacy because they'd been invited to go. And that was the majority of respondents to the survey. We also had reports that people had taken their voucher, but it hadn't been scanned. So there might be an element of underreporting of how many we used. And this year we've really tried to emphasize to managers the need to discuss this at team meetings and to work with staff to allow them the time to be vaccinated if they would choose to do so. So yes, I think we have already seen more uptake than we saw last year. It's still maybe not as high as we would like, but the focus is on removing barriers to those who would like to be vaccinated and haven't already been vaccinated. That's what we're trying to focus on, and we will do so next winter too.
Julie, do you want to follow that up?
No, as you said, as I've just had flu and I'm on day 12 now. And honestly, I've never felt so poorly for such a long time. And I take a flu vaccine every year. I go and pay for it. And this year I didn't. So I really encourage everyone to go and get their flu vaccine, because it looks like it's going to be a bad year for it.
Is there anything we can do to improve the numbers of our staff so that we are clearer about those people who are eligible through other routes, who have taken up the opportunity to have a vaccine, rather than those for whom we've offered vouchers and they have or have not taken them up?
So is that what can we do to advocate for people to receive their flu jab? Sorry, can you clarify the question?
Yeah, I'm getting a bit deaf here, Noreen.
Oh, sorry. Can you repeat the question? Sorry, is that how can we advocate for people to take up their flu jab? Or
Well, that, but how can we then record the fact that they're having their flu jab?
I see.
As opposed to we've offered vouchers and we know that that's relatively low.
It's often
There may be some who feel that I don't wish to have a flu jab for whatever reason, which is absolutely fine. That's their right. But for those who have taken up the offer, either through us or through other means, it would be good to, I think, to know for sure whether they have or they haven't, particularly people who are going into care homes where they're dealing with vulnerable people.
It's my understanding that within the council there hasn't been an appetite to record the vaccination status of staff. That's my understanding. Some of our NHS partners do that, and they request that staff inform them if they've had their vaccination elsewhere. But yeah, my understanding is that that was not something that the council were keen to do. And by that, I mean recording the vaccination status of our staff.
Oh, okay, right. I've got Steve and then Lucy to comment.
Thank you, Chair. You pointed at me when you said some councillors might think people shouldn't have flu vaccines. I don't think that. I think it's a personal choice, and I don't care what people choose because it's none of my business, and nor is it any business of this council whether its staff choose to have a vaccination or not, and nor should we ever stick our nose in it. It's entirely personal choice. The idea that we need more advocacy, the advocacy is everywhere. You get social media, you get emails, everybody is telling you all the time, have a flu jab. The NHS is constantly railing about how terrible the year is going to be, even though it did completely disappear one year out of some strange mystery. And my view of it is each adult can decide for themselves if they think that a flu jab is right for them. And that should be all that, it should end there. That should be all there is that matters about it. Thank you. Okay, Lucy.
Thank you. I'm going to half agree with Steve on this one. In that I fully agree that it is absolutely up to individuals whether they have a flu jab or not. The bit that I don't agree with Steve on is that advocacy is everywhere, and I'm not in quite the same places on social media as Steve is, but I do not see loads. I mean, I have heard quite a lot of stuff about how this year is a bad year, but what I don't think we're very clear about is the number of people who are entitled to a free vaccine. I think people are very confused about that. And I think they're also I think there's quite a lot of people out there who think, well, actually, I'm perfectly fine and healthy. I don't need a flu jab. And therefore, if I go and take up time at my very busy GP practice, that's not particularly helpful. So the part of the message that I think and this is my personal perception, isn't necessarily getting across is the benefit that that we get as a population from people who are comparatively fit and healthy also getting the jab because they are in contact with people who are at risk. And I think it's that sense that by reducing the amount of flu that's around on the bus, in the shop, and particularly in care homes and schools, that by doing that, you are helping to protect vulnerable people. That message, I'm not sure we are getting across as well as we could do. And of course, it's a personal choice. But I do think that the message about vaccination needs to be that it's not about protecting yourself, it's about protecting other people. And that's the case for vaccinations across the board, whatever kind of vaccination. And it's also the case for flu vaccines. And I do think that maybe
we as an I mean, this meeting is an opportunity to put out a press release where we can talk about that. And maybe we should ask Julie to be on it because she can she can really persuade people. I'm sorry, Julie.
Richard.
It's important that officers hear different and the public hear different views about these things. I'm completely a militant for as much advocacy as possible on vaccinations, and I regard the anti-vax people as, you know, being responsible for deaths. And this council has a role in promoting vaccination, and I personally want to say I celebrate that role. And if anything, I want to see more done. And I don't recognise or identify at all with those who've spoken differently on that issue.
Yeah, okay. What we're not discussing here is whether people are anti-vax or not. That is not the issue. The issue is whether or not people have the right to say, I'm not going to have a flu vaccine because I don't think it's appropriate for me. And my concern is that we are offering these vouchers for frontline people who have contact with vulnerable groups. And those frontline people, we would expect them to have a DBS check or whatever a DBS check now is now called. I just feel that sometimes we should expect them to have a flu vaccine check. But it's up to officers. I think this is an operational matter. Richard.
Firstly, I agree with what you've just said and support you. But secondly, we have also been discussing advocacy. Not, you know, obviously people have a right to choose for themselves in the end. I don't disrespect that, but it's about the amount of advocacy, the effectiveness of the advocacy, and this county council's role in promoting it. And I don't want there to be an outcome of this discussion that sends a signal to officers that we're not completely for that.
Patrick.
Yeah, thank you, Chair. Just to assure committee that we do a huge amount, both through Sally's team and the public health team, working alongside the NHS around the wider communication around the encouraging people who are at higher risk groups to take the vaccination. For our staff who are working with vulnerable adults and vulnerable people, we provide the opportunity for them to take vouchers and use other ways in which to secure a vaccination, and that can be done in their own time, and hence why it's really difficult to then try and track who is and who isn't having vaccinations. But our continued focus is very much on making sure that you're thinking about the person that you're supporting or you might come into contact with, and ensuring that you're thinking about those, not just about yourself, because you may not be in a high risk vulnerable group, but actually because you are working with those high risk groups, it's important that you take your own precautions. And vaccination isn't just sitting there alone. There are other mechanisms and other measures which you should do, which is around just general hygiene that you should have. You know, we were encouraged about that during the COVID period, about hand washing and other ways. And so you have to adopt those similar measures and mechanisms when you're working with the vulnerable groups that we do.
Any final comments? Oh, go on, David.
It's really, I mean, it's said in the update. Obviously, we've been quite lucky. Sorry, Julie. We've been quite lucky in the east of England. I was reading yesterday about in Wales, Caerphilly, they've had some really serious outbreaks. So one of the things that I was interested in is what's our kind of, if we do get hit by something as bad as they've had, do we have an extra level of protocols that come in as far as like shutting schools, etc.?
We have a really close relationship with our partners in both the UK Health Security Agency, the ICB, and wider NHS England region. And those things are dealt with as a system, and we will be a valuable member of that system. And we have different, depending on what sort of incident is happening, there are different levels of management. These are all quite well established, as you'd imagine, from local incident management to an MOU. We have a health protection MOU in the local area, and then the next level being incidents on a pandemic scale. So there is a graded response to local incidents that will involve each of those members of the system, who we have very good relationship with and are in regular contact with. So hopefully that's reassuring that if there were some similar incident locally, we would be in a good place to manage that, and it would be picked up by the council's emergency preparedness and response team if required. And yeah, those processes are in place.
All right, thank you very much. A very interesting discussion. I'm glad that we brought this paper for debate today. It is only for noting, we're not required to deliver any particular recommendations on it. So we've reviewed and noted this update, and as I say, no vote is required. Thank you. Thank you, Lauren. So we move on to item 6, which is the finance monitoring report, which can be found on pages 65 to 106 of the agenda pack. Patrick Warren Higgs, the Executive Director for Adults Health and Commissioning, will introduce the report, and Justin Hartley, Strategic Finance Manager, is also available with a colleague. Justin, do you want to say who your colleague is? Or sorry, I do know. Akua is there. I beg your pardon, Akua. I wasn't paying attention. Right, carry on, Patrick.
Thank you. Yeah, and thanks. And Justine and Akua will help me out, but I will set the scene, hopefully for committee. So the paper presented before you is a report on the financial position of the Adults Health and Commissioning Director as at the end of October 2025. The overall forecast position for the Adults Health and Commissioning budget for 25-26 at the end of October is a forecast overspend of £4.2 million, equivalent to 1.8% of the annual budget. That includes public health grant within there, and there's a slight underspend forecast of £63,000 within the public health service within that directorate. The table at 3.1.1 shows you the detailed breakdown of where those areas of cost pressure are. And if I draw your attention to the line of learning disability and prevention, you can see that the variance still sits there at 6.9 million. And that's the major reason for the cost pressure, with the implications of the ending of the pool budget on the learning disability partnership with the Integrated Care Board in March 2025. And we continue to see the burden of that particular decision whilst we do a huge piece of work to try and address those areas of underspend and cost pressures. The Directorate has received in this, so far in this year, we've received 2.9 million of corporate funding, which was agreed at SRMP committee to contribute to the LD pressures. And Justine could talk a bit more, but what we've done is we've rebased all of the figures as an assumption that the 2.9 million was received at the beginning of the year. Otherwise, some of the charts would have seen a huge drop in our forecast position at a particular point in time, and we didn't want to do and confuse committee in that. So it's been reflected as the full year pressures. In addition to the pressures on services for people with learning disability, there remains a number of challenging saving targets from 24-25 and in 25-26, which we may struggle to deliver in full in this year. And as I've highlighted earlier, significant work has been progressing to reduce the forecast pressure on the Adults Health and Commissioning budget, and we've managed to achieve an additional £2.5 million worth of mitigations, and they're reflected in that forecast down to 4.2 million. The key factors that continue to be likely to impact on the forecast throughout the remaining month is that demand continues to be difficult to predict and can vary significantly from month to month. We're particularly heading into a winter period, which has its own challenges, both in terms of supporting people to maintain their independence at home, helping people get out of hospital quickly if they need to into hospital. And as the earlier discussion leads us to, we're often the impact of some illnesses which are seasonal, namely flu in particular, where we have to manage and support people, and that can have an impact on our future demand numbers. Vacant posts have led to underspends against staffing budgets, particularly for the director within the public health team that's been going through a reorganisation and now is establishing itself into a permanent structure. We've got pressures from the provider market continue to be felt. We've had national insurance commitments which have had an impact on providers, and our inflationary pressures continue to be seen in uplifts that are requested and required, and we continue to negotiate on those arrangements with the market. The particular aspects of some of the provision and location of the care market makes it placements are more difficult to source, and therefore that can at times create additional cost pressures. In terms of the adult social care debt, This continues to be a huge challenge for both the Directorate and as the overall Council has reported to the Audit and Accounts Committee last month, continues to be a subject of great scrutiny because of the size of the debt that we see within the Directorate. It stood at 23.8 million at the end of October, up from 22.9 million at the end of September. Debt over 1 year old was 11.9 at the end of October, and that was up from 11.8 million at the end of September, compared to a balance of 9.3 million in March 2024. Overdue debt with health partners, and this is a positive, stood at 2.4 million at the end of October, down from 2.5 at the end of September. And there's been a huge piece of work done by Justine in particular and the team around addressing the outstanding levels of debt with the Cambridge and Peterborough Integrated Care Board. And we're now at its lowest level for a number of years. And we continue to work to try and address that 2.4 million as they move from a Cambridge and Peterborough Integrated Care Board into a Central East ICB. So we want to address that whilst we're in this transitional period into that new arrangement. There are some particular charts which show that the overdue debt is sensitively felt where the debt is aged. So usually over a period after about 2 years, it becomes a greater particular pressure. And if I draw your attention to the table at 3.2.7, which is on page 70 of your pack, you can see that the two lines are, there's a darker line which is 730 plus days overdue, and then a lighter grey line which is 366 to 730 days overdue. And you can see that in April 25, there's been a big steep rise in the levels of overdue debt in that 366 to 730. And naturally that will, if we don't address that as part of our age debt work, that will naturally fall once it goes beyond 730 days into the darker line, and that will then create a further spike into that age debt, which we know the older debt is particularly challenging to recover. Debt over 366 days increased rapidly in the early months of the financial year, which was related to backdated charges from 24-25, and then that will naturally fall into the age bracket if we don't recover that money straight away. Table 3.2.8 is an overall age debt by debt status, and this is helpful, hopefully helpful for committee to see, and this was shared at the Audit and Accounts Committee, to see the different elements that consist of the age debt arrangements and the timescales in which that debt has remained. So you could see that the big numbers are particularly around the Court of Protection. There's aspects around awaiting service response, which is where the debt and the income collection team have referred it back to the Directorate for some further comments. Those people who we supported who have passed away, those where we're pending probate and settlement of account is a further area of pressure. And then we've got some other pressures which are around legal action, ongoing legal action, and unapplied income, which is a negative, which is some offsetting of those costs. So that shows you, hopefully shows a detailed breakdown of those particular points. Paragraph 3.2.12, it shows some of the service improvements that both the adult social care team and the debt and the income collection team through the Adult Social Care Debt Board is overseeing those work, which is both around systems and digital process improvements within adult social care and debt, and the resources in terms of additional capacity to help us address that. As Justine and Akua with me today, I'm happy to take any questions, Chair.
Thank you, Patrick. Justine or Akua, do you want to add anything at this stage?
No, not particularly, but I brought Akua with me because if there are questions about practice, then they're kind of Akua's side. She's really involved in the debt thing. So I think it's really important when we're talking about debt that you get the sort of social work side of it as well as the finance side of it.
Mike.
Thanks very much, Chair. I'd like to ask a question. If we could go to page 98 of the pack and the savings tracker. We've got an amber thing on the savings there for enhanced response service. And we've got there, I think it's 75,000 of savings that are not realised. And the reason we're given is that it's due to an error in redundancy figures given originally. And of course, with the end of the enhanced response service, we're losing something as well as making savings. There's people who are doing very useful work there who are going out. So I'd like to ask what exactly the nature of the error is and whether there's as a result of this error, we've gone ahead with a change involving, I'm assuming it's compulsory redundancies, but I'd quite like an explanation of whether a lot of this has been done by voluntary or people who wanted to get out anyway, or whether they're genuinely, they are compulsory redundancies where people who wanted to continue doing this important work wanted to stay. But the worry I have is that we've got completely different figures of savings now. It's a third less than expected, if I've read the statistics right there. And I'm wondering if the decision might have been different if we'd had the correct figures in the first place rather than the error. Thanks.
No, before you come back, Patrick, any other comments from people? Go on, Lucy. Okay, well, I've got a similar question on the savings, that there's quite a lot of ones which are identified as black still, and whether or not there's anything more that can be done for those in this financial year, or whether they'll all transfer across to either base budgets or savings for next financial year.
I might come to Justine for some of the detail on the ERS, and then I'll come back to it. Do you want to just pick up the first point, Justine?
Yeah, so in terms of the deliverability of the saving, it's Amber in this financial year, but the full savings are delivered on an ongoing basis, because obviously the redundancy costs are one-off. I think it's just effectively it's pushed some of the saving into the following financial year. So it doesn't create us an issue on a longer term basis. I think the other thing I would say, it's not ERS still exists as a service. This is a change in the service, a reduction in the service rather than a deletion of the service. So yes, I think that fundamentally answers the question in terms of it is a timing issue really, that has just pushed it back a little bit in terms of deliverability.
If I could just follow up on that. So the paper and the consideration around the ending of that particular nighttime arrangement of the ERS was that we looked at our activity during the evenings. This is a service that supports the NHS and particularly the ambulance service, because this intervenes where people have fallen, and there's a decision where we could maybe reduce some of the pressures on the ambulance service. We had conversations with the ICB and the ambulance service around the decision to take away the service during the evening hours. They felt that they could manage with the levels of demand that they would expect to see without that service being there. So people would not be impacted by it because they felt that they could continue to support that. So when the conversations and the consideration of this was taken, we based it on particular elements of redundancy and the reality of the redundancy situation. And it was voluntary redundancy. There was opportunities for redeployment within other parts of the service. People chose to leave or chose not to take the jobs which were available. The reality was it was slightly different, and as Justine says, that's done is just push some of that full year saving into 26, 27 and onwards.
And my comment, okay, so Luke,
sorry, on the black savings.
And the black savings.
So on the black savings, there's a view that they won't be delivered in year. That doesn't mean to say that we've taken our eye off the ball and just rest on that. We continue to try and find ways in which we can achieve those savings. But there are on occasions where we've overestimated our ability to collect that income, address that saving in year, and therefore we have to make a decision of whether it's red and some of it will be achievable or whether it won't be achievable in year. So we demonstrate it as a black saving, but we do continue to focus on that as we do all of our savings targets around making sure that we maximise the opportunities to deliver on them.
Okay, Lucy and then Richard.
Thank you for the reminder. That's very helpful. Thank you for your question about the black savings, Graham. I think it is really important that we really interrogate how many of those can be moved into red by the end of the year. And also for the ones that remain black, we obviously got something wrong in terms of the year at which it doesn't mean that the projects were wrong, but the expectation that that level of saving would be delivered in year is a problem. So I think thank you, Graham, for drawing attention to those. I think they're really important. It is also worth flagging up the blue ones, and I think we need to recognise that there's always going to be a certain amount of some things will go better than expected and other things will go less well than expected. You're not going to just end up with a green column, but there are definitely more black ones than blue ones, and we need to be trying to make sure that those are better balanced. I do understand the pressures that mean that they're likely to be balanced in the direction that they are, but we just need to be mindful about them. The thing that I particularly wanted to talk about was in the main paper at 3.1.4, which talks about all the work that has been done to get the overspend kind of back down to a more manageable level. And I am extremely grateful because I know that an enormous amount of effort has gone into managing the overspend that there is in adult social care, and particularly the impact of the higher than expected costs in learning disability, which is the core reason that there's a big overspend. I just wanted to draw attention in that paragraph to the final bit about the use of adult social care reserves, because it really emphasises why we have those reserves, and why we put them in reserves rather than in base budgets. Because when we were discussing the financial plans this time last year, there was a lot of concern from the adult social care team about the numbers that we had put in for particularly demography. And I know that you and Richard were very nervous, Patrick, about the numbers that we had put in for demography in adult social care, because the numbers of older people coming into our service didn't really match what was going on in our surrounding areas. So we put that reserve in place because we were really nervous about the demography. Actually, it looks to me as if the demography hasn't done anything unexpected or changed, that actually the predictions around demography were okay. The bit that wasn't was the predictions around the learning disability thing. It sort of flags up the difficulties, the real difficulties of budgeting in an area like this, where it's so difficult to predict what the demands will be and what the costs for different demand-led services are. But reserves are a really good way of managing that unpredictability, because it means that we do put the money in, we put it in because we think we may well need it, and we have very tight budgets. And then when we overspend in one area, we can cope because we have reserves. And as we go into our budget planning process this year, I suspect we'll be in a similar position, that we will be setting very challenging budgets. And I know that there's been an enormous amount of work that's gone on looking at the inflation and demography figures, which are the ones that really drive our budgets in this area. They will be tight again, and we will need reserves again. But thank you very much for all the work you've done.
Richard, do you want to just comment, and then we'll let Patrick deal with both those?
Thanks. Let's just get to my note. Firstly, on the learning disabilities, we had a full discussion about this last time, so I don't think we need to repeat what was said then. But Patrick, in his answer last time, said we're now painstakingly going through individual packages. So just the progress on that I think we need to keep an eye on. And in the text, it said reassessing packages. Does that mean that we're just ourselves reducing services to people with learning disabilities? It seemed a bit implicit in that wording, so I can't but raise that question. The spending on mental health is under, and I just wonder why. What's going on there, and what are we doing about it? On the section of debt, I understand the need to do it. I do support it. It's a very thorough section. I think it is disproportionate to the rest of the report. You know, I think how well we're spending in terms of the quality of what we're doing and analysing the variances is what I'd expect to see in this report. Yet almost half of the report is just on debt recovery, and I don't think that is proportionate. So I give that feedback. I would also like to see numbers and action where debt has been waived or reduced for poverty or compassionate grounds for individuals, which is an important part of how we should deal with it. And it's only debt recovery from a financial point of view to minimise debt, this authority that you read in that section. I would like to see analysis to that to show that we are upholding some principles there and are prepared to be flexible where that is the right thing to do. And finally, I'm glad that the Leader of the Council raised the issue about the reserves. And I think she set out very properly what our expectations were. So I don't want to comment on that, but I would just like to hear from Patrick or Justine the current levels of the reserves and the strategy in this year, what's going in and what's going out in this financial year, so I can understand that. And that is referred to it, but I didn't fully understand it in the text. But thank you as ever for this report.
Okay, thank you, Richard. Patrick, do you want to pick up those points?
If I do most, then I'll look to Justine for the kind of detail on the reserves bit. So, thank you for the comments around the work that we've done around both trying to address and support the market. As I touched on through the opening introduction, the demand and demography and the way that the market changes and can change quite dramatically is a significant factor in the way that we have to look and manage our budget. And whilst we work within individual teams and then within the service and then ultimately within the directorate, we regularly meet as a leadership team to look at the whole picture and the pressures that may go up or may go down. And yeah, the demand and demography this year, last year we saw some dramatic changes, particularly for older adults during the summer months. This year we've seen some slight changes for older adults, but that seems to be coming back up to the norm. Learning disability is really the legacy of the packages that we've taken on, and just to assure both Councillor Howitt and the committee, at the most of the reassessments are around the balance of funding arrangements between the council and the ICB for what we would describe as joint funded packages of care. There were a number that we were in dispute with going into this financial year, and therefore we had to carry the burden of the full cost, which is where the additional overspend comes from. Of those numbers of cases that are in dispute, we've agreed arrangements with the ICB of how we will now review those. NHS England have advised us, and that work is progressing, and we're hopeful that that can start to have an impact on our numbers as we progress through the rest of this year and into next year. But at the moment, we have to go on the worst case scenario because that's the position that we're facing. So it isn't reassessment and reducing services to people. There might be instances where services are somebody's in residential care, for example, and also going to their day service during the week. And therefore, that's in effect double funding because a residential cost is for 24 hours, 7 days a week. So there might be some discussions with providers about how we've arrived at that point. But I think they're more of the detail, but just to assure you that this isn't looking to reduce services to people. The other aspect that we are doing is we're working as a team, we're looking at kind of a methodology to understand how we've arrived at this point of a significant cost pressure. Is it about our funding splits with the NHS? Is it about our relationship with providers? Is it about our lack of kind of strategy around commissioning and the types of provision that we want? Is it around our transitions from children's services? So how do we support young people into adulthood without that kind of expectation that it's residential or continued residential, etc.? So all of those aspects are part of a methodology that we're working through to try and fundamentally understand the makeup of the budget and how that's arranged. But at the moment, we are trying to manage it within the current cost pressures that we've got. So that's the LD one. The mental health one is again one that it was a cost pressure. It's at the moment it's dropping, but we may well see that it's not something we're seeing within our kind of demand on our services. And it may be a comment that Akua or Justine would want to add on. But yeah, we continue to keep an oversight on that, because whilst this month it might be slightly under, next month we may well find that the pressures have come back up, which is what we saw earlier in this year. Justine, do you just want to pick up on the reserves?
on that mental health issue first, if that's right, and then do reserves. So just to put the reserves into context, and it comes back to what Councillor Nessing was saying just about the levels of demand and demography and how we forecast those. Last year, we saw a really significant growth in mental health. We haven't seen that same growth in numbers this year. So because we saw that significant growth before we did the business plan, we put extra money into mental health, and now it's leveled out again. So our trends in terms of the numbers of people who come to our services are just, they're not straight lines at all. And it's a constant sort of challenge to try to forecast that as best we can. With mental health, we've just not seen the growth this year. It's almost like we saw a sort of sudden spurt last year, and then it's leveled off again. So reserves, the level of reserves is set out on page 102 of the pack. So the level of adults risk reserves at the end of October was 4.7 million. That's post the sort of resolution of all of the LD issues. That 4.7 million has been sort of built up over time and sat there for a while. We have got, the only assumption that we've got in the report at the moment is that an overspend, if one arises on the integrated community equipment service, will be funded from those reserves. So at the moment, we are forecasting 289,000 over on ISIS, and we're forecasting that comes out of reserves. There's nothing else built into the report at this stage. Obviously, the council's finances are not in the greatest position at the moment, and that could change in terms of a requirement to use some of those reserves to offset the adults' position if it continues with an overspend. But in terms of the current report, the 4.375 million that I'm forecasting at the end of the year is after that ISIS drawdown, if it's needed. And obviously the ISIS service is under a new provider at the moment, so it's quite difficult. We're still working through what the actual costs look like they might be this year and whether that will be an overspend or it won't be. So that's the only assumption in here at the moment. But yes, 4.4 million-ish of available reserves at the current time.
Thank you, Justine. Patrick. Oh, sorry, Akua.
No, that's fine. Just to add to what Patrick said around the work we're doing for people with learning disabilities, just so that you're aware, the joint funding meetings have started, and also where practitioners and the ICB will review their needs. So it's very much driven around people's needs as well. So I know there's some questions around, is it cost driven or is it people centered? And I think we're really clear that people remain at the heart of practice, even where there are questions around finances as well. There's also an escalation panel in place if agreements can't be arrived at as well. And there have been some challenges, but I think everyone concerned and everyone involved in the work is really clear that this has to work in the interest of people. So people are very much focused on doing that work. And I think there was also a question around compassion and debt. And I think the practice approach is very much about practitioners who have relationships with people, talking about the issues surrounding the debt that may have been accumulated over a period of time, working with families, working with carers, working with loved ones as well. And so that work we've got a slightly different approach in that we are expecting practitioners to have these difficult conversations with people, but there's also another team working alongside service managers and team managers to really have oversight over the debt before it grows and becomes really problematic and entrenched as well.
Thank you. Patrick, do you want to
add? Yeah, just to add really so two things on to Justine's comment. One about the reserves is we recognise, and committee will be aware, that these are one-offs. So they are almost as a last resort, but they are a good resource to have and an essential resource to have, particularly with the kinds of market. It isn't exact science with people, and it's about how we support them, how we respond effectively to all of the changes that may well happen during the year. So it's healthy to have, but it's in a vital part of our business that we continue to have that there. The bit around the kind of demand and demography, as Justine touched on, is that we had a period of we'd lost some of our historical knowledge because of the COVID period, but certainly from 2020 onwards, it's changed some of our data and our demographics because of the nature of that period of our time. And that's had an impact on some of our future forecasting. But what we are doing is we're working within Sally's team and the council's intelligence and insight to help us around some of our future demographics, our future projections of populations, and trying to be much more smarter in the use of data so that we can be better and more accurately reflect what we expect to happen with our population. But as I say, that it's not an exact science with people, and we'll do as much as we can in our forecasting. But sometimes throughout the year, you see these changes which aren't always spotted. What we try and do is historically look back to understand what happened there, and that helps our future planning.
Thank you, Patrick. Any other comments from anybody? No, I think, thank you, Justin, Akoya and Patrick. So we have noted the Adults Health and Commissioning Finance Monitoring Report as at the end of October 2025-26, and noted the update on adult social care debt. Thank you, everybody, for your comments today, and no vote is required on this. We move on at about 13 minutes to 12 to the item 8, which is the Adults Health and Commissioning Performance Monitoring Report for Q2 of 2025, which is on pages 107 to 154 of the agenda pack. This will be introduced by Patrick. We also have Sarah Bai, the Head of Performance and Strategic Development, and Val, the Consultant in Public Health, with us. Patrick.
Yeah, thank you, Chair. So the paper in front of committee is a report on the performance monitoring information for Q2 for 25-26, which is the 1st of July to the 30th of September. The performance management framework is what it does. It builds a clear performance process linking individual services performance all the way through to strategic decision making, and it's supporting the council to embed performance at the heart of everything it does. The most recent data for indicators for this committee can be found in the dashboard at Appendix 1. Hopefully the dashboard will go through information which will set out current and previous performance, current and previous trends, red, amber, green status, which is a particular way in which we highlight our performance and the movement of some of our performance. And then it also, the Appendix 2 also clears around some of the changes in performance and a description and commentary given. For committee's awareness, 2.8 highlights what the red, amber, green, or the RAG criteria is, which red is current performance is 10% or more from target, amber is less than 10%, green is on target. In terms of 3.1, that's the current performance of the indicators monitored by committee. You can see we've got 7 which are shown as within red, and they're at 30% of our KPIs, and then the amber and green consist of 6 and 8, which is 26% and 35%. There's one indicator that is currently in development and will be added to the dashboard when finalised, and that's around the percentage of children in the 20% most deprived areas achieving a good level of development at the age 2 to 2.5 years. In terms of summary of the performance, we've brought these together as a directorate, but they are broken down into 2 elements. One's around the adult social care services, which is indicators AHC 01 to 013, and then the remainders from 016 are the public health indicators. I will highlight in particular that we've got a number of the results from the survey have been published, which are contained further, and I'll pick those up around our adult social care survey. New contacts for adult social care, so people contacting for either services or information or advice continues to remain high per 100,000 of population, but our conversion rate in which we support people requiring formal care and support continues to remain low, which highlights our effective prevention, information and advice offer. There's strong performance within the delivery of short-term services, which are maximising independence, and that clearly leads on from that previous area, which is around how we intervene and support people approaching services. Safeguarding continues to be an effective area of practice, with performance in line with national and statistical neighbour averages for reducing or removing risk. The number of people who have not received a review for long-term care and support needs within the last 12 months remains at a lower than statistical or national comparators. And we've got something around client level data will be used to publish ASCOF ratings in the coming weeks and enable us to produce data benchmarking. So client level data is breaking our information down from that kind of high level summary So nationally, they'll be able to report on individual elements and individual people, and the outcomes framework will be reflected in terms of our ratings and scorings on that. We do continue to have an increasing number of people aged 18 to 64 where their needs are met within a residential or nursing setting, and that's something we've got to focus on, and a piece of work is underway to try and address that around reducing that number down. And we have a large proportion of people aged 65 plus having their long-term support needs met in their own home or in a community setting, and with less people needing admission to residential and nursing care. Number of carer conversations continues to remain high and above target, an average of 320 a month, although the rate of carers assessed or reviewed per 100,000 remains at a lower level when compared to regional and national. The number of people receiving a direct payment, and this is something committee has looked on previously, is around the work that we need to do. It's improved slightly, but there's much more work needed to be doing that, and we have a clear project which is underway around addressing direct payments. And the percentage of care homes rated good or outstanding by CQC continues to remain above the target of 80%. It was 81% in Q2. That includes all care homes in Cambridgeshire, not just those commissioned by the council. In terms of the public health indicators, which are 016 to 023, just to highlight some of the key ones are the proportion of children aged 10 to 11 years classified as living with obesity in the 20% most deprived areas. The aggregated data from 2021 to 24-25 showed that 28% of children in school year 6 and living in the 20% most deprived areas were obese in comparison to other areas where the average was 17%. 017, the percentage of births that received a new birth visit by a health visitor. There's an improvement going there. In Q2, the ongoing improvement was sustained. Percentage of smoking cessation, we've touched on that. Val might want to pick up on that one. The achievement against the target for completed NHS checks. The check programme aims to identify risks and prevent cardiovascular disease and other conditions targeted at people aged between 40 and 74 years old with a diagnosed condition. It checks for risks associated with those conditions. Performance was severely affected during the COVID-19 pandemic, but since 2022 there has been ongoing improvements, exceeded in 24-25 the target of 60%, and in Q2 we'd achieved 60% against the annual target of 67.5%, so again positive. Emergency hospital admissions due to falls continues to be a big factor for us. It's one of the major factors and the largest cause of emergency hospital admissions and the need for long-term care amongst older people. In 23-24, Q2 continued the upward trend in the rate of falls, with 2,050 against the national rate of 1984 per 100,000. So we see high numbers of people falling within Cambridgeshire. And a review of our falls prevention service has been undertaken, and that will inform the refresh of the falls prevention strategy. And then the sexual health late diagnosis in people first diagnosed with HIV in the UK. Early diagnosis and treatment can mean a life expectancy comparable to those not infected with HIV. And in presumably 23-24, the numbers of those diagnosed late was low, but the proportion is higher at 49%. And then just in terms of every winter, so section 5, survey of adult social care service users. Every winter, NHS Digital directs local authorities to conduct a survey of people receiving long-term care funded by adult social care. The 2024 survey took place during January and March 24, and results were published nationally. So we're looking back to the autumn of 24 from these being published. There's some details there, but 5.5 highlights Appendix 2, which is the body of the report and the full analysis of the survey. But key findings are that the survey asked several questions around the respondent support needs and what they could do for themselves. Performance worsened in one area related to respondents' level and type of care needed. How well your home is designed to meet your needs was 87%, or 87.7% of respondents answered positively, which was slightly lower than 2023 when it was 88.2%. 92% responded that care workers usually or always respected their background, cultural life and religious beliefs, improving from 89.6%. And questions in the survey which explore the respondents' quality of life and experience of care and support service in response to the question about how people feel they have control over their life. 79.6% felt they had adequate control or as much control as they wanted. That was higher in 2023, which was at 76%, and higher than the England overall total of 77%. 5.6.1 is the response of the survey can be broken down into district geographies, and you can see in that table below of the percentages of those particular questions, and we're highlighting there around the different changes. The survey responses indicate that performance has decreased in the following areas. People who use services find it easy to find information and advice about support fell from 65% to 62%. And we know that people finding information and advice is a real challenge. The council's Our Future Council programme, through the Digital Data and Technology programme, which Sarah's part of, is actually looking at ways in which we can use other technology to help people to find information and advice, because a lot of those people who we see presenting for services all require information and advice. So if it could be easy for them to find, then that would improve both this indicator and hopefully reduce the number of people who are presenting. And then the next point is a proportion of people who report they have as much social contact as they would like fell from 49% to 43%, lower than the national average, but similar to the regional average of 43%. Happy to take any further questions, Chair.
Any comments, questions? Tom and then Lucy.
Thank you, Chair. So just to jump in, first of all, on the Adult Social Care Service Users Survey. So I note from the table at 5.6.1, so you have said that actually there are small sample sizes involved here, so not necessary to read in too much, but I do note with concern that East Cambs, where my division is, has the lowest proportion of positive responses, but more questions than any other district. So yeah, I take it that there are small sample sizes at play here, but are there any other underlying factors or any other insights?
Just pick up Lucy's comments. We'll take Lucy as well and then come back, Tom.
Thank you. I've got a couple of questions about the KPIs and the targets. The first one is on indicator 004, which is long-term support needs for adults met by admission to residential and nursing care homes per 100,000 population. I find that indicator difficult to understand and difficult to see why we've got that as our target. So I don't, maybe you could comment on that one. The other two that I wanted to raise are indicator 008 and 0010, I think. Oh God, I've lost it now. That's annoying. No, it's 9 actually. And the reason I wanted to ask about those is because they are quite important indicators and both of them are declining quite significantly. And I wondered whether there was a key reason that you understand why they're declining and therefore what we're doing about it, or whether that's something we need to be focusing on. Thank you.
Do you want to pick up those various points?
Can I just go to Sarah on a couple of those points, because you might have the details, Sarah, that I'm not as familiar with.
Absolutely. In terms of the first point around the results of the survey that we send out, absolutely some of the sizes of those particular cohorts are smaller, and we do look at the various cohorts. So we do also look at things in terms of older people, or whether somebody's primary support reason might be learning disability. So we can do a little bit more disaggregation of that information as well. So we do try and have a look at some of the underlying reasons, and also look at the quality of life survey that we do more generally across the council as well. So things like social contact, we would see as an issue within the quality of life survey, and also how that impacts it from our kind of adult social care cohort as well. So we do a number of things to try and build the insights, if you like, of why some of these things might be happening. We also have to reflect that people answer the survey with their own particular set of circumstances, and some of that might be, we ask it in perspective of adult social care, but people's lives are not so easily compartmentalized. So people are answering the survey questions, they're answering on a whole range of issues that might be impacting on their life at that particular time. So we do try and have a think about the selection of questions that you've got there is quite small. There's many questions in that survey, so we do try and bring all of those together. So we do look at the results, we overlay it with other information that we've got, and then we think about with our kind of public health colleagues the different ways in which we can start to impact some of that positive move to shift that. We're also just about to prepare the next year's survey, so that will be going out shortly as well. So again, we try and do that comparison to see if there's been a shift, although recognising that the table doesn't outline the difference from last year to this year, but we can certainly provide that as well. And then in terms of the other queries around the other elements, so in terms of 004 and the residential target, we did a bit of work around benchmarking when we set some of the targets before, but we've now got client level data, as Patrick mentioned earlier. We had benchmarked previously and set our target based on what we knew of other local authorities and where we needed to be in terms of the admissions, bearing in mind also the work that we need to do, particularly around learning disabilities as well. It's something that I think we do need to review now. We've got client level data, which is a more consistent data set that will enable us to re-look at this. So once our ASCOF measures are published with our kind of regional and national comparators, we're going to be doing another look at all of our targets to make sure that they are truly reflective of both the kind of where we see ourselves as a council, but also where we want to be, so that we don't set ourselves a target that's too low and that we're not achieving some of that. So we will be doing that piece of work in the next quarter once we've got that publication. In terms of reviews, absolutely, we've seen that decline significantly. We were much higher than our regional and national comparators. We're now more in line with them, but we have seen a decline in our own performance. So we absolutely need to look at that. We have been talking to our operational teams about the demands that they see, how that they're prioritising elements of work, and often you have to prioritise safeguardings that are coming in or new assessments to make sure that somebody's got care provision in place. But we are looking at the resources that we have allocated within the teams to be able to do that. And we're also introducing some digital products that will also help. So we've got Magic Notes, which we've invested in, which will enable the capacity of people to get through work more quickly. And we know from the work that we've done that somebody having a planned review is much better for their outcomes and also costs than an unplanned review. So we absolutely want to make sure that we're getting that balance right. So we are definitely taking the opportunity to use digital where we can to really improve our performance around that area. We're just rolling that out now. So I'm hoping that we'll start to see some improvements in the coming months. And then finally, around safeguarding, I've highlighted the decline in that performance to our quality and practice standards team. They've been doing some audit work on safeguarding as well. So they've looking at our performance data with the audit work that they're taking out, that they're going through at the moment as well, so that they can bring all of that together to think about whether there's anything else that we need to be doing with our operational teams or our MASH function to support the improvement of that particular element. So a number of pieces of work going on.
Okay, thank you. Any other comments, questions? Richard and then David.
Thanks. Just to get into my notes again. Firstly, I was also going to ask about safeguarding, but I'm happy with the answer that we just got. But I do think it's important that we hear the results of that work in future reports on performance. On one of the ways of increasing client reviews being digital, quote, digital tools being rolled out to 3 community teams, unquote. Can we hear from the officers what that means in lay terms that we can understand, and why that would affect the improvement that is hoped for in terms of client reviews? On carer reviews, this report says the same that we've had now in several of these performance reports. It seems unchanged. We're pleased with the increase in carer conversations, but we're underperforming in terms of formal carer assessments. My feeling from previous debates on this is that the officers are wanting the increasing conversations to be maintained, and that's a really important part of the strategy, but are committed to increasing the number of carer reviews. But it has to be said, we're not seeing that in terms of any result. So can I check that I'm right, that both of those are the objectives of the officers, and could they comment on how we can improve the number of carer reviews that we're undertaking, and which is people's rights, carers' rights to have the review under the legislation, and we're underperforming. On the survey, first of all, I really welcome the survey. I think it's got lots that's really positive in it, which I'm really pleased about. I really like the additional questions that are put in by Cambridgeshire County Council, including especially the one on respect for cultural and religious beliefs amongst our different service users, and we're performing well on that. I really welcome that a lot in terms of this council's performance. On social isolation, it's obviously worrying. My reading of that is it's a national problem. I don't think that we're doing better or worse on that in Cambridgeshire, and I think it's a challenge for local authorities in a society where social isolation is getting a bigger and bigger problem. And I don't think there's an easy answer to it. It might be a strategic item for another day. But the big thing that jumps out is nothing to do with the quality of service, which looks great in most respects. It is on information and advice. People don't like and don't find it easy to use the means that we have for information and advice. And we know the website is clunky, and it's not easy to find out the right email addresses or phone numbers for people. And the changes that are planned in the contact centre, are they really going to dent that finding? So I think we should be self-critical about that. And it has said before, including by the former Vice Chair, Councillor Van der Ven, very strenuously. She's not here, but she made a big point about that. I agreed with her, and I think we haven't got the improvement that we need to see. And I think we should just accept that and then really deliberate hard, not blame anyone, but deliberate hard about how we can improve it. Overall, thank you very much.
Thank you. David, and then we'll get some comments from officers and wrap up if we can.
Yes, it's a very quick one, and it's on the 020 RAG report, which though amber, from experience, a fall is the start of a lot of cost and a lot of change in a lifestyle. I'm just intrigued on the difference between falls in hospitals, falls in care homes, and falls in private accommodation, and the difference in percentages in that. And I see a lot of things about, again, exercise programs, but also kind of minimizing fall risk within houses, and the kind of processes we could get behind that.
Okay, just before you come back, Sarah or Val, let's just have Mike, and then we'll definitely try and
Thank you very much, Chair. It's just something that has very quickly occurred to me. On the bottom of page 121, we've got a green thing on 013 of it's a target percentage of Cambridgeshire care homes rated good or outstanding by CQC. And I can see why we've got a target of 80% or whatever, but I had a quick question technically. Caller 2 is the last thing that's reported on that. So the 81.2% we've got here, is that a result for a quarter or for the 2 quarters? I'd imagine the first 2 quarters of the year we're looking at, or is it a whole year? But the other thing I'd like to say about that is that suggests that 1 in 5, about 1 in 5 of the care homes looked at are getting needs improvement or inadequate. And I do like to try and keep mentioning that when people are getting those those scores on this particular thing with the CQC, you often read the report and something terrible has happened that really should never happen. And so but I'm just interested in what that stat says to us of how many care homes over a period have not got that good or outstanding. Wondering if also if any of our care homes have had outstanding in recent times, because I mean I think that's possibly something we'd be interested in. Sorry, thank you.
Okay, let's. I think Lewis wants to come in quickly, and then we'll definitely try and wrap it up with comments from officers.
Thank you, Chair. Very specific one on performance item 16, child obesity. When was the integrated child wealth management service commission? And do we have any information, any performance day to date on these three tiers? And how will these results affect or influence the funding and the design of new services to tackle childhood obesity? That would be my question.
Thanks, Lewis. Quite a range of topics there, Sarah. I've scribbled a few things as well. Hopefully you can pick up the main points. If there's anything, we'll come back afterwards. Thank you.
I will do my best. Thank you, Chair. So I'll cover the adult social care ones and then I'll hand over to Val for the couple of public health queries as well. So taking Councillor Howitt's initial point. So reviews and the digital tools that we're using. So Magic Notes is the product that we've purchased, which enables us to have a recorded conversation with somebody, and that will use that information to put that into a review template, and then practitioner will use that. So it takes out the administrative burden. It doesn't take away someone's professional judgment, but it just eases some of the admin that goes alongside that. So we're hoping that that will enable there's more time for practitioners to have those conversations with people. So we're hoping that that will have an effect in terms of reviews. And as I say, we're just rolling that out to our community teams at the moment. So I'll happily send you some information about what that product does in terms of the technical spec for that. Carers, conversations and assessments. Absolutely, we know that that area is something that we've talked about many times at committee. We're bringing some information to spokes soon on the strategy, and I think the refresh of the carer strategy will give us an absolute opportunity to start looking at that assessment piece. With unfortunately Akuya's left now, but in terms of our new service directors and thinking about their input into our strategy refresh as well. So again, I think there's an opportunity for us to look more closely at that performance element around assessment. And with the ASCOFs being published very soon, we'll be able to see where we rank in terms of kind of regional and national, although we know that we're going to be towards the bottom end of that because of our processes to date. But absolutely, I think we're taking that opportunity. Information and advice, I absolutely agree. And we know we've had a huge amount of feedback from people about the website. But we have taken the opportunity, which won't have been seen in this survey, but we're hoping will be reflected in the next one, to do a piece of co-production work. So we have worked with members of the public, other people within the system, to understand the client journey and the types of information that people will want to see on the website. We've looked at our analytics, and then we've tried to follow somebody's journey. What are they trying to look for, and how do we make that as easy as possible? So we've done a huge amount of work with people to understand what they want to find and how they want to find it, and we're going to hopefully make that changes to the website in the new year. So we hope that that will start to make some of those things easier for people. But I agree, there's absolutely more to do, particularly with AI. I think there's definitely opportunities there, and also our customer experience program within the council is working on avoidable contacts, so making sure that people don't need to chase around trying to find the number for somebody that they're working with, when we should be doing more to give them the information up front. So there is work going on around that. Finally, in terms of the CQC care home stat, I will just have to double check where they take that. I think it's cumulative based on the CQC assessments that have happened to date within the year, but I will double check that I'm correct in that. And it, as to say, it is all CQC inspection. So it might not be just the ones that the council commission, but is all of the CQC inspected organisations. And I will double check with our contracts team in terms of how many outstandings we've had from our CQC providers that we currently commission, and let you have that information. That was a quick, rapid tour through some of that, but hopefully that gave it enough information. And I'll hand over to Val for the public health ones.
Okay, thank you, Sarah. In relation to a question around falls and the falls review, and I think it was where do falls happen? It's quite a complicated picture because private accommodation is linked to what you define as a fall that ends up in hospital, or a fall that happens in someone's home, and it's teasing out that can be quite challenging. But I think the main thing is that we want to prevent these things happening. So each of the districts on a home improvement service, which answers your question about what are we doing in the homes. I think in terms of the care homes, our service is piloting a program in one of the care homes at this moment, in fact, or will do shortly when our new service starts, to look at what more we can do in care homes, what are the issues and what we can prevent. There's also something about in private accommodation. One of the things that is available, for example, there's an app that some people might use about raising awareness of what people can do to prevent falls. I think there's some wider messaging that needs to be done around that as well, in terms of getting the messages out around prevention of falls in one's own home. And then I think it's making sure that people end up there are different types of prevention services for falls, and making sure that people end up in the right service which is appropriate for their risk, so that people at very high risk, high level frailty end up in a more intensive service. But I think at the moment our services are focusing very much on what we would call services in the community to keep people active and engaged. Then a service which we call FAME, which helps us, it sort of strength and balance exercises, which again contributes to prevention. So I think it's kind of an emerging picture at the moment, and I think all these things have to be put into a strategy which we would be developing over the next few months, and it would be good to report back on that, I think, at a future time. In answer to the question about the childhood obesity service, I think what was different about this child obesity service was that it brought together early intervention, prevention services, so community work, working with families, with a more intensive service, which has been quite challenging, working with children in terms of recruitment and continued engagement for children and their families. And it took a little while for the provider to try out different models, but the most recent outcomes we got were positive and better than we've ever had before. And also the other element of that, we set up a referral pathway from children who are, for instance, in SEND or are they have particular needs, so that they can be referred directly into this extra support in the Tier 2 service. But I can't give you a breakdown of the outcomes that we have to date from that service outside of this meeting.
Okay, thank you very much. And that's very helpful, thank you. So good debate on performance matters. We're asked to scrutinise, which we have done, and comment on the performance information presented, and no vote is required. So thank you very much for that. I suggest we now have an 11-minute break, which will take us up to 12:30 precisely, to stretch your legs and so on, and then we'll move on to the risk register. Sarah, thank you very much. Okay, thank you very much, everybody, for coming back. I think we'll make a start. So we've got the risk register and then the agenda plan and training plan to deal with before we finish today. Sarah, do you want to tell us about the risk register?
Thank you, Chair. So the report provides that adults' health the report provides the Adult and Health Committee with an update on the key risks facing the Adults' Health and Commissioning Directorate, including public health, and that is as December 2025. It outlines the approach to risk management, summarising risks, and highlights the main strategic risks, and particularly those that are escalated to the corporate risk register. There are 11 risks currently on our directorate level risk register, with 2 of those escalated to the corporate risk register because they've reached the threshold of risk score to do that. One of those is around that our safeguarding arrangements fail, and the other is around the relationships within the ICS, our integrated care system, lead to worse outcomes for our population. I'm happy to open to questions on the risk register.
Okay, any comments, questions? Did we establish, Sarah, whether this risk register is looking forward and therefore is thinking we're not going to have enough money for next year, although we know we haven't got really enough money for this year, or whether, as Sally has done it, it's we now know the money for this year and therefore the risk register for public health finances can go down a bit? What was the answer to that?
So we continue. So I think there's always a risk. So the risk is something that hasn't yet happened but may happen. So we absolutely continue to look at the risk. So we do a quarterly review of the risk register, but we are looking forward in terms of the likelihood of something happening. So we look at downgrading some of the or scoring the risks differently depending on the likelihood of something happening. So within the current year, it may be that the likelihood is reduced because we start to see and understand where things are at. But going forward, which is why we do a quarterly review, that risk may start to increase again. So we look at all of them, particularly financial risks, because we know that can change on an ongoing basis depending on a number of internal and external factors. So we continue to review that and also link that to the corporate risk register as well. So where there's an escalation or varying factors within our directorate that may not reach the level for the corporate risk register individually, we do help to contribute to that overall risk, which in the corporate risk register may be that longer term strategic planning, whereas we're looking at what's happening on a more granular basis, for example, for public health or demand in adult social care, and we continue to review that. So the risk hasn't yet happened and the likelihood may be reducing, but we still consider it to be a risk on an ongoing basis.
Okay, that's helpful. Thank you. Has that given anybody any time to think of any other questions, or we have no questions? Oh, go on, Mike.
Sorry, Chair. Apologies. I thought I would be coming back dead on time, but obviously no. I think my watch must be slow. Yeah. Okay. Thanks. I'd like to just go to page 166 and risk 4. That providers lead the market, and in particular, we've got provider failure due to inability to recruit an appropriately trained workforce, and I think we've already had examples of that happening. It worries me that this is, actually has happened. This is a risk that's bordering on red a lot of the time. The quick question on that as well. Under the monitoring, we've got the failure management standing operating procedure. I'm wondering if I've seen that. I would quite like to see it, assuming it's not confidential. But and my thought is as well is that if we were to move towards more insourcing, it might mitigate the risk we have on this. And I've got another question, Chair. Should I go on to that on a different page? So if we look at page 177, I suppose it's a bit linked. It's about whether we might have a failure of safeguarding adults under our care, and particularly if we go down to page 181, this talks about it in our commission services, and I'm feeling that we already may have had those sort of failures and the consequent damage to our reputation. I mean, we recently had a domiciliary care provider where the CQC report was inadequate in nearly all respects, and in particular, something that struck me about that CQC report was where it said something that I would consider a never happen issue, where the staff were inadequately trained and were actually fitting people's catheters incorrectly. And I feel that that is such an issue with human dignity and the proper provision of care. You know, I just consider that to be a catastrophic failure. And of course, that was the Ranis Limited that people have been talking about for a while. And yeah, again, I think there are things that we perhaps ought to be able to do to mitigate that risk, including having more in-source services and also having a pool of council staff that could be sent in to rescue failing services. And yeah, possibly I've previously made waves saying that we should be able to be an employer of last resort for care workers when they are stuck with a failing provider. Okay, thanks.
Okay, thank you. Just Patrick, do you want to comment on this about provider failures and the ability of the market to pick up problems?
Thank you, Chair. So I think these risks reflect that kind of a market that you're describing, Councillor Black. So it's not a safe market, but it's not a high risk market. I think the risks are reflected as such. I think the safeguarding risk at 15 reflects our view around the position of the whole market, not just one provider. The capacity in the market currently exists that if we need to, we can support people, and we have done that to move across to other providers. So we take an assessment of whether we need a provider of last resource arrangement. We don't feel at this moment in time that we need a provider of last resource arrangement. You would need, if you've got more registered care provision, then you may well have a registered manager, etc. For CQC, you would need a registered manager to step in and run that. So I think that there's a provision within the sufficient capacity within the current market. The arrangement, the fee increases that the administration has supported has allowed us to pay higher wages and higher fee rates into the market in previous years, and we've got a capacity in the market that allows us to move people and where we support them. I think our contractual and oversight of provision is strong. We work closely with the Care Quality Commission, and the risks are reflected in that. I think in terms of your point around safeguarding, I think that's the overall safeguarding position that we hold. It isn't just on care homes; it's for people in their own homes, it's for people that live with family, etc. So again, it's an assessment, it's a judgment of our risk of the whole provision, our whole responsibility around safeguarding. It isn't just around safeguarding in a particular provider or a particular part of the market.
Okay, thank you, Patrick. Any other comments, questions from anybody? No, so we are being asked to note the updated Adults Health and Commissioning Risk Register. No vote is required. Sarah, thank you very much for presenting that item. The final item of business for this morning is item 10, the committee's agenda plan, training plan and committee appointments. These can be found on pages 187 to 194 of the agenda pack. Rishinda, would you care to let us know of any changes to the committee plan, agenda plan since publication?
Thank you, Chair. There's one change to report and an additional report to the January committee meeting, which is impact and consideration of legislative changes for the adult social care workforce.
Okay, any questions from anybody? Richard.
Sorry, once again, just get to my notes. This criticism is meant constructively, but I think today has been a far too light agenda. We had 2 strategic items from public health, which I thought were very relevant and very informative, but nothing in terms of strategy on adult social care, which is the vast majority of staff and money that is spent under the aegis of this committee. And I do think that is a failing. Right? If you think the last committee meeting was September, the next one is virtually wholly on finance. So the next time we can look at adult social care strategy will be March. Is there really nothing that should be scrutinised by us as members between September and March on the whole of the adult social care provision of this council? And I do think, I said at Spokes, I thought it was light. I'd hope that would be heard, but I do not think that just having agreeing contracts, a finance report, a performance report, and a risk register is a creative or useful way to use the member time. I'm not asking for reports on all these issues, but I've just done a quick shortlist of the sorts of issues we could have discussed. We could have looked at the market issues in more detail, both the diversity in the market, the sustainability and the quality. We could have looked at the partnership with the health service, including current arrangements around discharges and the progress there. We could have looked at data sharing to make our joint efforts in partnership delivery more useful. We could have discussed the input from this council into the social care review nationally. We could have looked at workforce issues, as Lib Dem colleagues have asked for, but we could review how effective they are at the moment and how they could be improved. We could have a special item on inequalities and anti-poverty issues in adult social care. We've got waiting lists. We could have an item just on the strategy with regard to dealing with the waiting lists. We could have a strategy about moving towards integrated neighbourhoods. We could have a report on enhancing co-production. And we could have one, bearing in mind what the leader of the council said early on, doing more. What more could we do on the mental health crisis? Now, the reason I quote all of those is not, as I say, I'm asking reports on all of them, but officers and the administration have clearly not really thought that any of those issues are relevant for us to discuss. And I just would beg to differ about that. And so what I hope to hear in response from you, Chair, is that that feedback is noted and that you will scrutinise future agendas far more carefully in advance.
Thank you, Richard. I have made a note of all those points. It would be helpful if you can, because you've clearly written them down, if you can email them to me and Patrick and Rishinda, and we can consider them further. And I would suggest we do that at Spokes or some other time.
I do thank you for saying that, but I just wanted to clarify. There are probably strategic issues that are not on that list that I don't know about that may be more of a priority. So it's an indicative list. It's more that I would expect the officers to come forward with more suggestions than they have done in all truth.
That's fine. And we were concerned that today's meeting might seem a bit light. In practice, we've had quite a good debate about the main topics today about public health and the tobacco strategy or a nicotine strategy, the flu update, and then the other things are a bit more routine. But it has given us an opportunity to have a good discussion about these things, whereas sometimes we wouldn't. We will still probably finish about 1 o'clock, and I think a 3-hour meeting is probably about the time that everybody really wants to deal with. But I will take away your thoughts. Certainly there was a topic that we had to delay to next time about the mental health early prevention and intervention and prevention tender, because we weren't really ready to discuss it properly, and we'll bring that back to another meeting. I'm afraid I'm not going to be here. Well, I'm not afraid, because I'm not going to be here in January because I'm visiting my children in New Zealand. So Lewis is kindly chairing that meeting for us, and then we'll take it from there. Okay, any other comments, questions from anybody? No, thank you very much. But do send that list, and I'm happy to accept that it is an indicative list. We need to review the agenda plan. Next is the committee training plan. Are there any comments on that? I will just put in my usual plea that these are put on by officers to encourage us to know what's going on, and the more that you can attend, the more helpful it is, really. There is a training session on Thursday, the 8th of January at 12:30 on business planning budget setting, which is open to all county councillors. And I would encourage you, particularly newer members, to attend that. Finally, we have committee appointments. There are no new changes to report. We reported a number right at the beginning. So that brings us to the end of this morning's business, and we'll meet next on the 22nd of January 2026. I declare this meeting closed. Have a good journey home, and I hope the A14 is a bit clearer for you this afternoon.